Perfect. So today I'm going to talk about the European openEHR network, something we invested the last months, and especially me and the people working with me, to make kind of a vision we think how the future should be. And that's also why I took the Star Trek slides. It's like this utopic view for the future. So anyways, we can skip that. Bunny Lassie already did that. So in the end, you know, when we're talking about facilitating health records, the IPS and all that stuff, in the end, what we want to do, right, we want to connect institutions and send data from A to B and collaborate, for example, for secondary use. And you know, we've been doing this in HIGHmed for around 7 years. And in all this time, we are encountering kind of similar problems. And so, you know, when we look at these problems, you know, the EHR is this utopic worldview of having all that health-related information to a patient. And we know it's not an easy thing, right? We've been trying this for years and years on, and you know, we got this really heterogeneous thing and structure and semantics. And what we in the end do, right, we're trying to standardize this to make an effective use of it, at least also between the system, right? You can also structurize it to do structured analytics. So typically what we do, we write extract, transfer, load processes, so you integrate the data into a format, for example, the IPS or OMOP or openEHR or FHIR, and then you go ahead for the project, do the things the project requires. Well, it's also the case, systems natively implementing standards like an openEHR, CDR, FHIR store. So if you have a project that, for example, the IPS is on FHIR, right, and you already get the data on FHIR, that makes it quite easy, so it's less of an ETL effort there. The problem we have in the end is we have over 600 subsystems in an average German hospital, and you have to integrate that, and it's quite a mess. And the moment you got outside of this hospital, it's not anymore 600 subsystems, it's amplifying, right? 2 hospitals, 2,200, and going on. So in the end, you know, what we're doing the last years, we said, okay, we need to find a way to collaborate. And what we did in the end, we come up with summaries for primary use, which, you know, the IPS providing essential health information for critical care, and OMOP doing this secondary use model for research. And we're transforming data there from the source systems, and then we usually for primary use exchange it. Some people exchange it also for secondary use. I think it's very stupid. Usually you can just share results, but I think it's like this legacy mindset, you know, you have to exchange data. But if we take a look at the EHR, you know, we've been nitpicking bits out of it. And we're doing this all the time the last 20, 30 years. But the EHR is much more than that, right? Even I write here laboratory and diagnose, but the reality is if you look at OMOP, you will have a daytime and a coding. That's not all what's left of the diagnose. We have much more in the system. And the same goes for summaries, right? I mean, these are products of their environment because we're lacking interoperability in the end. But we're continuing this all the time. And if we would spend the money we've used for all of that, we would, for standardizing our EHR, we would be probably flying around with cars right now. Yeah, so I think instead of having interoperability driven by less is more things, we should really try to reach for the stars, yeah? So the problem in the end with this, we're also duplicating a lot of work, right? And I'm not saying these things are bad, it's just the fact that, for example, at Charité, we have an I2P2 instance, we have an OMOP CDM, we have an openEHR CDR, we have a FHIR instance, and in the end, all this stuff is mapped from the SAP system to these different instances. So we are really replicating ETLs all the time. And we all know ETLs are really expensive, right? So it's really unsustainable, right? If we would use this money we're putting in to also standardize our EHR in the same moment we're moving in summaries, I think that would help us really a lot getting there. And then there's the problem, right? When I say nitpicking, we're missing out a lot of semantics. And I mean, semantics is life, right? So these also have an impact of quality of care. The less you provide, the harder it gets. Well, you could forget, well, we did this example where we had our AI researchers, so we have a really big AI lab directly beneath, you know, as neighbors of my office. And we did, you know, let them have this pulse investigation, but the people didn't capture their exertion. And we, you know, what ended up, we were diagnosing patients with, a high pulse, but in the end, these people have been running on the streets measuring their pulse. So you see, that has quite an impact. And for research, research is getting complex every day. I mean, I've working with these people, and the request is just staggering. And if we continue like this, we'll not be able to provide that. I'm already reaching limits right now. And if we continue nitpicking, I think, we're just adding up on a pile of unstable things. And sometimes I have a feeling, when I look at research projects, they deliberately try to throw away as much semantics as possible to make it obviously more easier to work with. But then even if you look at it, right, most of the people don't even know if these semantics even have an impact. I don't know either, but we're not even using it. So we have no idea, for example, when we do disease predictions, if all the semantics we would provide actually make an impact on the network. And if you think, that's quite stupid, isn't it? So I really think we can do much more on top of summaries and just secondary use models. At some point, you have to start. Maybe it's naive, right? But you have to reach for the stars. In the end, we're talking about patients' life. We're talking about care. And I think if there's any domain on Earth where we should really try to get things as good as possible, it's that domain. So, I was laying down after, in bed after, doing all this research in the last 7 years, and I'm thinking, why I'm still stuck with this? I mean, can we not do better? And then I thought about the openEHR platforms we're having, and, why we're not connecting these, right? So why we're not doing this? Because in the end, even though you may not be able to provide all the data, let's be realistic, that's a hard thing to do, but you at least have a model to be able to represent this data, yes? So if you think, you won't go out there standardizing your EHR using OMOP, it's not possible because it doesn't provide you the semantics. Anyways, so why openEHR, right? I think, when we were looking at FHIR and OMOP and all this stuff, and the good part about openEHR is it really tries to standardize an EHR. And as I said, when you want to move bits and bits out, you should do that in the same moment. You should standardize an EHR because that really helps in the end. And the good part is obviously if you have already an openEHR CDR, you're just reusing existing architecture. And as said, the model provides much, much more than just summaries and secondary use models. You can do whatever, I mean, sure, obviously there are borders, but the archetypes, think about Heather's talk yesterday, right? She said from the tobacco summary, it has 30 fields. We use 2 of them, 2 of 30. So that's not quite a lot, and the rest is there. Then we got international models, so we have the same model base in the end, at least for the international archetypes between CDRs, so this gives a really good base for collaboration. We have our own query language, and what I think is very interesting, having the same model, you're able to share results. You don't even have to share data if you want to do, for example, research, right? You have a statistic, whatever, calculation, and it's working on international archetypes. You can do the calculation everywhere, right, and get back the results. So this is also very strong for research. So right now I'm, openEHR, but the world, is different. Not everybody's going to use openEHR. And this is interesting because in the end, the last 7 years, what we did, I started with FHIR R2. So I initially came from IG, moved to FHIR, and then to openEHR, and did some DICOM. We recognized, and some other papers recognized, openEHR is really good in being transformed into less expressive models, right? You're coming from this big inclusive model, scaling it down to specific use cases. And Diego gave the talk yesterday, right? We are having OMOCL, which will be hopefully done in January, February. In that moment, we'll have all international archetype being mapped to OMOP. That means the moment you say openEHR, you say OMOP. It's not a different thing anymore. Same goes for FHIR Connect, which is a little bit more complicated, but I think we're getting there. Anyways, furthermore, it has a stable model. So OMOP is changing vocabularies. We have FHIR releases, right? But openEHR doesn't have this fluctuation. It's quite a major model. Still, you have updates of archetypes. That's how it goes. But it's just way less fluctuations than the other guys have. So I think, personally, that this is really good. I call it always lingua franca for integration into other standards. Yeah? And obviously, not everybody's going to use openEHR, which is fine. That's just how the world is. And I think, that's free market. And we know it's an effort to adapt. It's not like openEHR doesn't have downsides. It's a lot of work, and it's also not the easy way. You will have, a lot to do, but some people do. Some people use openEHR. And I think with those some, we can try to achieve much more. So, you know, I went calling the guys, you know, because I know them, I've worked with them and said, why we're not plugging these things together, right? Why we're not doing this? And they were like, right, yes, why we're not doing this? So, and this was, in the end, how the European openEHR network was founded. In the end, now we have quite a collections of locations you see on the right. In the end, this vision is that we kind of stabilize and make it more regular, that we have collaborations between these institutions. In the end, they said the same vision of this open electronic health record and ideas. And also, this shouldn't be just like technical stuff's always easy, right? Come on, lads, you know, it's just setting up some bits and parts. The really hard part is also privacy in contracts. And I really want to have a Charité doctor come and give him the documents he needs to fill out to work with the Karolinska people or the Val d'Hebron people. So this is also part what we hope the network will achieve, yeah? Having this clear workflows. You want to work with them, you have to do this and that. And I'm going to talk a little bit more about secondary use stuff because obviously I'm stuck in research for the rest of my life. And I also think it's just more regular. You have collaborations between hospitals based on research. I mean, I still can go to Barcelona and break my leg, right? That could happen. But, you know, just out of own experience, we have a lot of collaborations in research. So anyways, how do we start this thing, right? It's this great, probably utopic vision to do. And, you know, we came up with this idea, why not do feasibility queries? So feasibility queries, in the end, before a doctor makes a study, he asks, how much patients do I have fitting these conditions? Like, in this case, we want to correlate, for example, diabetes 2 with kidney cancer because we think there's a correlation. So you go to your hospital, you ask, do we have enough to do a study, right? Because if I have 2 patients, I don't have to do a study, right? And, you know, we thought, why not facilitating discounts? Privacy-wise, you're not sharing patient data, right? What you're sharing is results. Plus, this opened up the collaboration then, because then the doctor says, oh, look, our friends at Karolinska has a lot of data. We would love to collaborate with them. What do we need to do? And this then opens up, in the end, you know, more collaborations between the hospitals. So what we're at with this? Yeah, so we set up 2 demonstration sites at Charité and Karolinska, which are running in the network of the clinic. So we're not talking about some guy's computer. It's actually part of the clinic network. Val d'Hebron is currently in setup. You know, we still have to figure some firewall stuff out. It's not always easy. It takes time. You know, it's just reality. Currently, we're testing on synthetic data. And, you know, you know, obviously, the federation worked quite well. I mean, we're just sharing counts, to be fair. Nevertheless, we just need, you know, in reality, we just need to plug the node now to the CDR, and we would have this thing up and running. Obviously, we can. And that's fine, yeah, we still have to do all the regulation around. But it's been really exciting working here. One more thing is, in the end, you know, the HIGHmed Association developed or contracted a cohort explorer tool, which is quite nice, because if you think about it, we can use the tool on the nodes, having actually a cohort explorer being federated throughout Europe. And having AQL in the end for the cohort definition. And it does also more. It has user management and project management. And HIGHmed Association is still continuing the development and, you know, being open also, you know, if you guys need a cohort explorer. So, you know, how does this work? As I said, you stick it on the node, and then, you know, the cohort explorer will just send the AQL query saying, okay, how much patients do we have of that? And the node will federate it through the network and get it back. And, you know, let's take a look how this actually looks. So, first of all, the Cohort Explorer pulls the templates from the CDR you're having. And so you can just, for example, I used the international patient. You did the question, you know? We can support the international patient summary plus on top much more. So we're not stopping here. So it was a wonderful question, right? But if we have the IPS, we can do it, right? Plus on top, as I said, much more. So yeah, anyways, you can select the template, and then what's kind of nice, you have this AQL builder, so you can click together, for example, a diagnose, and we're going to add here, I think it's hypertension or something. To be honest, I didn't remember. It's too much ICD code. And then in the end, you know, the query will be generated. We're replacing it with account because the nodes doesn't accept usual AQL queries. You have to have account. And then you get out the results. And here we have the Karolinska and Heidelberg and Charité. I mean, this is now, you know, for that you need to know AQL, right? What is more exciting in the end, we have this thing called criteria. So people sit down that know openEHR, they define like filters, and you can reuse this filter, so that's much easier for researchers. And then you're just filling in the things you need, which I think is quite exciting, right? Because people don't have to know AQL. And oh yeah, anyways, that was a result with some chart. So what is the status of the tools? The Cohort Explorer works locally and federated, so you can go there and download it and actually try it on your own CDR if you want. Yeah. For us, we will take around, yeah, everyone's going to take a picture, something for free real estate, yeah? Anyways, the federating, well, we need 1 or 2 weeks more to get it really clean. And where's Florian? You know, the guy did it, you know, is he in the room? So you need to go to talk to this guy if you want to know more how the Cohort Explorer is working. The AQL federation tool, it's just federating counts, so don't expect it to be, you know, something really crazy. It's already open source, but we have to clean it up. So give us like 2 weeks, and you know, you can try the notes around and play around with the Cohort Explorer. Anyways, I want to make sure one thing. This is not this openEHR lone wolf project where we think we can change the world. That would be really stupid because a lot of collaborations out there. So we are really trying to make this parts of other projects, yeah? Because in the end, we're trying to improve patient care. And this is something we should all work together on, and not just like us and them. So that's why we are also participating in EU projects. For example, we have this EHDS consortia together with Katzalot, Charité, and the openEHR International, where we try, you know, to, in the end, work together and share these experiences. And also we're doing modeling in Cancer Core Europe and some other projects. So you see, it's not this us thing, it's a European thing, and we really try to learn from the experience from each other. Anyways, so what does the future bring? After the conference, I will sign a study, so we'll do this with real CDR data, and you know, we'll need to do the ethics from A to B. So this is, you know, this will happen. It will probably take half a year until we have all the ethics done at the location. Federated learning is obviously an open topic. We're still discussing and trying around. We discussed about data shield, so that's really high on the list. We have a cooperation contract underway, and I have to say at this point, we're all doing this in kind. No one is being paid for this. We're all sharing this vision because we think it's the right thing to do. And that's, you know, obviously this is not, you know, being, you know, really super fast, but it's getting there. And I really think we have a cooperation contract in 1 or 2 months. We tried before the conference, but, you know, people also have to do their everyday work. Then privacy and data protection is the thing. We have tremendous experience in HIGHmed with that. We already did it. It's GDPR compatible. I think it's just a matter now transforming these documents to a European level. And we already have research collaborations underway, so we're actually working. Okay, anyways. There's one more thing. We have an openEHR digital conference hosted by HIGHmed in Berlin in the end of January, where I'm going to talk about future-proof data integration center based on openEHR and doing mappings to FHIR and AMAP. So if you want to hear about that, come and take a look. Yeah, thanks so much. Just some special thanks to all the guys being involved, Karolinska, especially also the Firewall guys, Galaxy and Tigerlonian and the Charité side. I mean, all these people, and Jordi's team has been really invested in the project and doing really great work. Just thanks so much for that.
Awesome. Now it's time for questions. Thanks a lot for sticking to the time limit, so we have room for questions. Do you have any questions? Okay.
Yeah, it's not a question, but it's a suggestion. I think that there is like a very precious things here. I think we can really push for an European project with this, because in the end, we can do more than most of the projects are doing right now. And I would suggest that somehow we manage to create like a European project for this, because I think it's very, very neat stuff and very cool stuff. Just not a question, but a suggestion.
That's a very good question. And actually, I mean, we're on that. We're in new tenders. We're part of the EHDS tender now. We are actually doing also the European exchange format. So we're bringing all this experience in. And I'm very optimistic that we can offer this as an optional thing to the EHS, along with all the fire stuff and so on. So why shouldn't we do that, right? Why shouldn't it be allowed for us to do more?
Severin, that was fascinating. I couldn't avoid but noticing that the UK is completely removed from this collaboration up to now.
You didn't sign up. I mean, I asked everywhere. It's like your fault then.
So this is exactly my question. Has it got to do with politics, Brexit, or is it just that we're not sharing on the same sort of cloud areas that you guys are using to share on the data? I realize that a lot of this at the moment is still, if you're trying it and you're utilizing data sets which may be research, and that's the other question. You see, in the UK we're completely gagged data-wise, particularly with research. So there is a divergence between what we've been hearing in this conference and this wonderful open sky thinking about sharing electronic health records, when at the moment we cannot do anything data share-wise that will not involve amazing amount of paperwork and bureaucracy and data sets which are just reduced to very small numbers. So my question is, what can it take for the UK to join up here? Does it need to come at a sort of political top level? Does NHS England need to be involved here? Or how can we initiate these collaborations? Because it seems to me that definitely this is the way to go.
This is kind of why we opened it up. Because we're driving this out of the hospitals, because policymakers didn't make this happen. And we said we had enough of it. So I went to the hospitals, why we're not doing this? You know, we don't need politics to do that. We can do it on our own, right? Because the GDPR, we have the EHS. There's regulational basis for this. And I think what we just have to do actually is push and show we can do it for them to understand how to do the policies and say, oh, really, you did that? Well, that's a lot more than we did the last 20 years. So how can we find that?
So the issues are still around governance. I mean, I work in one of the largest trusts in this country. Yeah. Okay, we provide care for several million population. And I'm here representing myself, a small clinician with a research interest and a vision on EHR, which is not shared by the wider organization. So the EHR record that we're utilizing where I work in Leeds, secondary and tertiary care are not talking to primary care. So we are in the, you know, not even Middle Ages, we're in the prehistory here. So how can I go to my CEO and say, I've just been to this conference, I think I'm the only person, by the way, from my trust here, so none of the IT guys are here, I'm a clinician. How can I go and say, this is the vision and I want to play with them?
I would just recommend you what I do. Get Jordi and Patrick Henning in a call with your CEO, because these are the guys they should talk to.
Well, Xavi worked with me for a while and then moved on, so yeah.
So what I can just tell you what we did in the end, right? I mean, Charité isn't also this open-air holistic thing, right? We're having our own research CDR, and they cannot stop me from signing ethics, right? So I'm just signing the ethic and doing it.
Oh, they can't stop me.
Yeah, that's bad. I mean, to be honest, I have a really great boss supporting us, and it's not like Charité is trying to stop this. No way at all. But they're also not like, you know, the CIO or the guys aren't coming saying, yeah, you're the best, here, take all this money. But in the end, I mean, it's just reality. I mean, Charité has other problems, right? I mean, Germany has a big demographic change. In 10 years, Charité will be missing 30% of the nurses. So this is the problem Charité have to deal with, and not that. So what we can do in the end, I mean, I'm in a lucky position. I have a super great boss, you know, helping me with that. So that's just, you know, you can just try to get the other guys and trying to convince your CIO. That's just how I've been dealing with it locally in the Charité, yeah.
But the hurdles are there, so we're still quite high.
I mean, yeah, the Christies, I mean, I talked to Ian about the Christies, and, you know, I think sooner or later these people are going to join, because in the end, but first you have to settle out things in your own environment before you join this huge utopic vision of that, which is probably really naive what I'm doing, who knows, but let's just try it, yeah.
Thank you, Severin.